Good afternoon, everyone, and thank you for joining the webinar, Reentry Planning During the COVID-19 Pandemic. We'll get started in another minute or so to allow for additional time past the hour. Good afternoon, everyone, and thank you for joining us for the webinar today, Reentry Planning During the COVID-19 Pandemic. My name is Marc Stern, and I'm the Senior Policy Analyst at the Council of State Governments Justice Center, and I will be moderating today's webinar. To give you an overview of the webinar today, we'll start with some introductions. Then we'll turn things over to Risë Haneberg at the Council of State Governments Justice Center, who will preview a checklist for reentry planning during COVID-19 that was developed by the Justice Center with guidance from the National Sheriff's Association. Then we'll hear about some challenges and considerations from the field, starting with Kari Hill at the National Sheriff's Association and Sheriff Peter Koutoujian at Middlesex County Sheriff's Office in Massachusetts. Then we'll hear from Michael Daniels in Franklin County, Ohio, and Sam Howarth in Bernalillo County, New Mexico, about COVID-19 in their jurisdictions and how their county teams are addressing challenges, especially as they relate to people who frequently utilize criminal justice, behavioral health, and social service systems. And at the end of the webinar, we'll hear briefly from Dr. Marc Stern, who is an affiliate professor at the School of Public Health at the University of Washington, and then we'll have time for questions and answers. Now to turn to some introductions today. We're excited to have 6 panelists joining us on the webinar today. We have Risë Haneberg, Deputy Division Director of Behavioral Health at the Council of State Governments Justice Center. We have Kari Hill, Chief Jail Advisor, National Sheriff's Association and Massachusetts Sheriff's Association. Sheriff Peter Koutoujian, Middlesex County Sheriff's Office in Massachusetts. Michael Daniels, Director, Justice Policy and Programs, Franklin County Board of Commissioners in Ohio. Dr. Sam Howarth, Behavioral Health Services Administrator, Bernalillo County Department of Behavioral Health Services. And Dr. Marc Stern, Affiliate Assistant Professor, School of Public Health at the University of Washington. Thank you all for joining us today. And before I move on, a few housekeeping items to note. During the webinar, you can ask a question at any time by typing it into the Q&A panel on the bottom right-hand portion of your screen. We'll respond to the technical questions as we go along, and we'll keep a running list of the content-related questions and hold them until the Q&A section. And this webinar is also being recorded, and a recording along with a PDF of the slide deck will be available by next week. And here you can see some pictures of our presenters today, along with their titles and affiliations. And same for this slide as well. And for some brief information on the Council of State Governments Justice Center, it is a national nonprofit, nonpartisan organization that develops research-driven and consensus-based strategies to increase public safety and strengthen communities. The Justice Center seeks to break the cycle of incarceration, improve health, opportunity, and equity, and expand the knowledge base of what works to improve public safety. And for the National Sheriff's Association, or NSA, it is dedicated to serving the Office of the Sheriff and its affiliates through law enforcement education and training, and through the provision of general law enforcement informational resources. NSA represents thousands of sheriffs, deputies, and other law enforcement, public safety professionals, and concerned citizens nationwide. And now I will turn things over to Risë Haneberg at the Justice Center to preview the COVID-19 and reentry checklist.
Thank you, Mark. Just making sure everyone can hear me. Good afternoon and good morning to those of you who are joining us today from the West Coast. Before I get started today, I just really want to also thank the National Sheriff's Association. They have been great partners as we work to not only develop this webinar, but also the checklist that we're going to be circulating here in the next few days. I also want to thank our other Justice Center partners, our Stepping Up partners, the National Association of Counties and the American Psychiatric Association Foundation, Bureau of Justice Assistance, and the many grantees that are joining us today, and also the Safety and Justice Challenge sites across the country from the MacArthur Foundation work. We are super excited that we've had actually over 1,200 people register for this webinar, and we're certainly hoping that this will provide useful information for you today. So we have been working over the last week or so in developing a checklist, which would be considerations for those who are being prepared for reentry into the community and transition, especially during this time of the COVID-19 pandemic. We understand that given any circumstances that it's definitely essential and needed to be able to pull together effective reentry plans for those that are being discharged from jails and prisons across our country. But with the added concerns around the COVID-19 concerns and health needs and so forth, we are pulling together a checklist that today I'm going to just preview for you, and then, as I said, we expect to release it over the next couple of days. The checklist is going to be a front and back page. I'm sorry to tell you it's going to be legal size, but we just had to try to cover as much information material as possible for you. It'll be electronically distributed. The first page is going to be a traditional checklist. It's going to cover a number of items that are going to be grouped according to first the COVID-19 medical considerations with the necessary kinds of questions you should be asking yourself as you're walking through the discharge process, and the necessary links to information, particularly as provided through the CDC. We also have listed legal discharge considerations. These would be involving the court orders, if there's instructions for reporting, and those kinds of considerations. From there, we move towards basic needs, shelter, food, internet connections, computers if necessary, the different kinds of basic needs that will be essential for the people that are returning to community to be able to function and hopefully be successful in re-engaging with the community. And then the health and treatment concerns that they would also have. As we have in particular worked through the Stepping Up initiative with jails across the country, working hard to identify those individuals as they are booked into jails that are screening positive for both mental health as well as substance use disorders and opioid use disorders, that we all know and understand that it's extremely important for these individuals to be properly connected to the medical and also supportive services that will be needed for them. Next slide. The second page then will, as you have completed that checklist, and if you have marked boxes that are color-coded, it will then direct you to the back side of the document where we have built in hopefully a on-the-spot resource directory for you as you are troubleshooting through and trying to effectively plan and provide guidance to the individuals at the time of their release. The kinds of things that you will see are advisories on how to connect those who need continued follow-up assessments and treatments in their return to the community, if they need to have appointments made with treatment providers, directions, especially knowing during this time period, much of that is being provided through telehealth kinds of connections. If you can, some form of a relapse prevention plan for those who are working through addictions, and also those who have current medications, prescriptions that would need to be either that they would be supplied to them at the time of discharge, or certainly that they would be given information and connection to pharmacies and access to their medications for their continued and uninterrupted use. Also, we provided listing and contacts linkage to other forms of federal and state benefits that may need to be reinstated at the time of discharge. Next slide. We certainly want to spend special attention to the population that are identified as high utilizers. Although many may have different definitions as to what they consider the high utilizer, generally we see that these are individuals that cycle between systems that are ensuring their public health and safety. We see that these individuals have frequent police contact, potentially EMS encounters, contact with jails, and also other kinds of service providers, shelters, et cetera, in the community. Preventing and identifying these cases, these individuals, in addition if they might possibly also be positive for COVID-19, can be even more challenging in addition to the challenges involved with tracking this population. So I'm excited to have with us on the webinar today our representatives from both Franklin County and Bernalillo County, where they are providing model examples of how this work is completed, as well as addressing the challenges that they are also dealing with during this time frame. But for now, I'm going to turn it back to Mark, and he will be introducing us to, again, the individuals from the National Sheriff's Association. Thank you.
Great. Thanks so much, Risë. And now we'll hear about some challenges and considerations for the field, starting with Kari Hill from the National Sheriff's Association and Sheriff Peter Koutoujian at Middlesex County Sheriff's Office in Massachusetts.
Thank you, Mark. I'm going to turn it directly over to Sheriff Peter Koutoujian. For those of you who know the sheriff, he has been a leader on a national level as well as in the state of Massachusetts, particularly with reentry programs. So with that, Sheriff, I would love to hear some of the challenges and some of the considerations you've had with reentry in the state of Massachusetts.
Thank you, Carrie, and thank you to the Council of State Governments, the Justice Center, for allowing me to participate. I do want to say that I am fortunate to be on the executive board of the Justice Center, and I always admired Council of State Governments from afar, and now that I'm closer, there's even more to admire than you can possibly imagine with an engaged, passionate, talented, and inspiring staff. So that's just my little plug, and a thank you to CSG. Now, it's been mentioned this is an incredibly challenging time, and I'm really grateful for the opportunity to share with some of the best practices that we've developed, along with many other shops here in the Middlesex Sheriff's Office. We were the first to have positive cases of inmates of any sheriff office in the state of Massachusetts, meaning we had to step in very early. And if anyone has any questions about this experience or any guidance that you seek, please feel free to email me or to call me or my office at any time. Next slide, please. Actually, no, let's stay on that last slide. So here you can see reentry begins on day one. We know this. This is just everything that we stand for in corrections. Reentry begins on day one, not a month or 6 months prior to your release. Today, nothing changes except that the difficulty of this reentry planning from day one or last-minute reentry planning. Sometimes we're having to adapt to a new reality. We are working on an accelerated decarceration plan. We have been for well over a month. We've had 417 individuals released in less than 7 weeks, a number through bail funds, a number through bail address in the Middlesex DAs, a number through our electronic monitoring program, bracelets. We have significantly reduced our population. In fact, it's been reduced by 25% since March 11th. We were at just about 800, which was a fairly record low for us in Middlesex County. Now we're just at about 605 in a very short period of time. And by the way, I will mention this again, decarceration is a social justice and philosophical and sometimes theological discussion, but when it comes down to dealing with a pandemic and what's happening inside your jail and creating isolation and social spacing, it is really important to do. Next slide, please. Some of the challenges in reentry are, the planning goes from months to days and even sometimes literally hours Even Friday we had a significant case we had reached out to the district attorney's office for to get him out, elderly, chronically ill. We actually, he became infected with COVID-19. He had to be hospitalized. He was actually being returned from the hospital on Friday, and suddenly, without any notice, we got the notice from the district attorney's office that that they were releasing him, and we had no plan in place. It was a Friday evening. I'm sure you can imagine during any time, especially this time, what resources are there. And my officers, not just caseworker, but officers, spent hours trying to make sure that we had something in place. Post-release navigation, we have a strong navigator system is done now remotely, mostly by telephone. The majority of the releases are pretrial, which also tend to be some of the sickest and most in need of care. It's always easier to plan for a sentenced end of stay date, but I just have to say this. The issues that present themselves now, even with end of stays, are significantly more complicated and make it significantly more difficult. So even when you're planning an end of stay, it is not the same as it used to be. In fact, we're seeing some cases where individuals at their end of stay, end of sentence basically, are able to walk out and become assaultive literally on the way out. And after listening to their phone calls, it's because they didn't have a plan in place. Even though we tried to work with one, they didn't have any family member to go to. They were going to be homeless, and they became agitated and hoped to stay inside. Housing and transportation options are limited. You can't access services in the community due to social distancing and stay-at-home advisories. They already have enough challenges anyway with transportation as well. Right now we're exploring opportunities with Uber and Lyft to assist with returning citizens in their transportation needs, especially those with medication-assisted treatment needs as well. Next slide, please. So our population, 80% have a substance use disorder, self-acknowledged. 51% have a history of mental health prior to coming to our jail, and 76% of those also have an addiction. So the continuity of care is one of our primary focuses to try to get them into basically into a program inside our facility, and then to maintain that program on the outside. So scheduling appointments we do with providers prior to release. We enroll them in Medicaid. We are an expansion state, so we're lucky in that way. We give them a kit from the Police-Assisted Addiction and Recovery Initiative, PARI. These are survival kits with 2 Narcans in them, a list of recovery support services. Actually, it's a telemedicine, telehealth opportunity with Boston Medical Center for their addiction needs. We give them a Medicaid ID number and contact information for a navigator. But what's also important is we just also started to provide bridge prescriptions for Suboxone to get them by those first few days while we make that appointment, and they all have an appointment after 1 day, to get them through that first day or two before they can get to that office. And also, if you're on methadone in our medication-assisted treatment program, then we'll provide you a letter so you can get that first dose at a clinic more easily as well. We have a family resources and outreach coordinator who facilitates reintegration to the home. That's a new position we created. I haven't been able to find one like it in the country, and it has been remarkably helpful in managing the incarcerated population, but their families and supporting their families. So in closing, I just want to say thank you again to CSG. This is something, these are new days. I think we can learn a lot from these new days, and I think that we can create a lot of opportunities for these new days, but we've got to forge through right now. So I'm grateful for the impressive work of my fellow presenters, and I look forward to our future collaboration with CSG and many others on this call. Thank you.
So good afternoon, everyone. This is Kari Hill, and it's really a pleasure to be with you, and also thank you to CSG for the extraordinary work that you are doing to assist the field. So as we look at reentry, one of the things that the sheriffs and jails, and whether you're a jail with or without a sheriff, what we do extraordinarily well is manage fluid populations that come in, that are transient, that have numerous maladies that may present upon intake. And the other extraordinary thing that our jails do incredibly well is the reentry piece. Even our rural jails who struggle sometimes with resources in the community are sometimes the most innovative and creative in finding ways to connect those leaving our facilities with a soft handoff into the community. But as the sheriff mentioned, and as we all know, now with COVID, the challenges with that are even greater. Now couple it with litigation. And some of you may not have litigation, but there are things I want you to think about, because whether you're involved in litigation or not, there are things that we want to make sure and protocols that you have in place as you're thinking about reentry and the impact it may have not only on your staff, obviously the inmate as they're about to reenter, hopefully with family and friends back into the community, but also the community at large. So as we look at some of the litigation across the United States, the petitioners are wanting mass release of inmates due to COVID-19. And one of the things that we have, all of the sheriffs across the United States and jails have pushed back, saying there's been no finding of deliberate indifference. As I've mentioned, the jails know how to incredibly well to do the preventative screening. This is not the first time we've had some type of a mass type of whether it be a threat of a bird flu, or whether or not it was Ebola just a few years ago. We know how to amp up our screening. So we understand how to do the preventative and how, in fact, then to provide the medical care and address it if, in fact, COVID presents. So part of that litigation defense has been that there is no finding of deliberate indifference. But many times the courts, and especially in Massachusetts here, found no deliberate indifference, but thought that because of the concerns for social distancing, that they would look at individuals who met certain eligibility requirements, there would be a presumption that they could be released. However, with that now comes an increase with how quickly these releases are happening. And mostly the concern with, is there a safety net for those that are being released to continue, whether they're MAT treatment, if mental health issues present, are there any type of treatment and or providers in the community that can assist? What are we doing about our shelters, who are many times at full capacity right now? And as you and I all know, we're balancing that public safety with that public health, so there is a successful reentry, not only for our justice-involved population, but also for the community at large. Next slide, please. So one of the things I want to encourage you to do, whether or not you have litigation involved or not, is working closely with your criminal justice partners. We look at the court, parole, probation, your district attorney's office. So many times you're going to receive some type of a court order releasing an inmate. And as the sheriff just mentioned, sometimes these court orders are coming at the very end of a day. At the end of a day, it was challenging before COVID-19 when we had time to start working on some of the release measures. Now we're down to hours many times, and many times the inmates, if they have been released from the court, want to go now and they don't want to wait. That's a matter of sitting down many times with your court administrators and talking about the challenges that these late orders present. We had that situation in Massachusetts, and once we brought it to the court's attention, those releases, if they're going to happen, and those orders are happening earlier in the day. Teleconferencing. Many of us have already been doing teleconferencing with the courts, although interesting, many of the courts were kind of pushing back on that, really wanting to have the inmate in front of them, even for non-evidentiary proceedings. So does your facility have the ability to amp up the teleconferencing, but also look at potential for Zoom hearings and conferencing? So literally we could take our laptops right to the inmates for probation, for parole hearings. So sometimes we haven't always had the infrastructure, but do you have that capability? And if so, now's more the time for us to get this in place. And wouldn't this be fantastic if we can continue this and excel it even after the COVID pandemic presents? Attorneys, because almost all of us throughout the United States have suspended visitation except for attorneys, and most of those attorneys only being with barrier visits. You have to remember that now we're limiting those visits, so how do the attorneys get access to their inmates? Do you have protocols in place so the attorneys can contact somebody in your agency? Hopefully it's a generic email you can set up that they can either email or they can fax and make a request to have a call with their with the inmate the next day, and approximately a time. Now, understanding in our larger facilities that makes it a little more complicated. You don't have to set up a separate attorney visiting room, right, for this. What happens now is you can let the attorney know, you let your watch commander, however it works for you, that the inmate, tell the inmate, your attorney would like to speak to you. They can make that call on the regular telephone calling system. If you need to, make sure that their cell phones are entered so that those calls are not recorded. but it's going to be incumbent upon us to show that contact information is published. Just give that contact information to the Bar Association so that they can let the attorneys know. Families and shelters. I want to make sure that as the inmates will say that I have a place to go, we are seeing families in shelters who are saying we will not take the inmate if they have not in fact been quarantined. Jails, for the most part, do not have time to quarantine inmates prior to release. We don't have enough notice. We never have, and definitely now during COVID. So please be aware of that. What does that mean? We had a female whose parents said that they would take her, and then upon release, they had told her that, in fact, because she hadn't been quarantined, she had to sleep in the car. Please don't let those tragedies happen. We want to make sure across the board that the shelters and especially the family members who are taking them are set up and understand some of those protocols. Release packages, as the sheriff mentioned, really important if you have the capabilities, whether it's Narcan, whether it's guidelines from the CDC that speaks to the social distancing, if you have access to masks and gloves or soap or ID. And sometimes jurisdictions will just give a black backpack that they can give maybe with these things. And then when law enforcement sees them in the community, they recognize that that black pack is an indicator that they're coming from the jail, maybe have been a recent release, and it makes a difference when we're interfacing. And last, please track your releases. It's so important to track our rearrests, overdoses. We've had inmates petitioning to come back in because they haven't had a place to go. But remember, our primary focus here is also that public safety, and we're balancing that public health so that we are absolutely looking out for the best interests of our inmates as well as the community. But we also, it's very important to track that. Next and last slide, please. Consider the use of navigators, as Sheriff Koutoujian has talked about. And if you don't have a navigator, you're not quite sure what one is, please reach out to Sheriff Koutoujian, his email, and or myself, or any of the contacts on this webinar. But individuals, are you tracking those that have been released? Are they getting to their, if they can, to any type of MAD appointments that they may have, or any of their mental health providers? Are they struggling? We've had several individuals who have overdosed as a result of some of these releases, and obviously that is of grave concern to all of the sheriffs and the correctional officers and deputies who work within the facilities, as well as their families. Obviously, telehealth and other virtual service provisions, are they in place, and can they be amped up to assist the inmate? What about transportation? It seems to be the greatest concern is how do we transport, especially now with mass trans being greatly reduced in the social distancing concern. Looking at partnerships with Lyft, looking at partnerships with other providers, is that an option for you? And by all means, reaching back out to your public health partners on housing and transportation challenges. And if you're involved in litigation, pushing back a little bit on the petitioners, help us to make sure that there's housing and necessary transportation for the inmates. We are all in this together, and the challenges are felt not only within the walls, but outside of the walls. And please know that the great work that CSG is doing, that the national sheriffs are doing, that the major county sheriffs are doing, that the American Jail Association, all of your partners out there are doing extraordinary work. Please reach out to any one of us if you have any questions or there's anything we can do to provide some of the protocols or policies and best practices that we've discussed. Thank you so very much for this opportunity. Mark, back to you.
Thanks so much, Carrie and Sheriff Koutoujian. And now I'll turn things over to Michael Daniels in Franklin County, Ohio.
Good afternoon, everyone. And I want to echo my colleagues' thanks to all of you who are on this, to my fellow panelists, and especially to the Council of State Governments, Marc and Risë, for all the work that they've done in putting this together and putting the checklist together. I want to be sure that we're respectful of everyone's time. That's the polite way of saying that when you follow Kari Hill and Peter Koutoujian, most of the hard lifting has already been done for you, because they have gone over this in an amazing level of detail and with an amazing degree of completeness. I just want to add a few things from our perspective in Franklin County. From a COVID-19 overview, we're a county of 1.3 million. As of yesterday, we had 2,005 positive cases, 307 hospitalizations, and 57 deaths in the county. That's a per capita rate of about 1.5 times better than the state of Ohio in terms of safety, and about 4 times better than the national average. And we give a lot of that credit to not only our governor, but also to our county department of public health and our criminal justice planning board, which many of you might call your criminal justice coordinating council, and the work that we have been doing together for years to have in place the relationships that were necessary that we could bring them to bear in this time of crisis. And so we, like the sheriff had said, we have decarcerated at a very rapid pace. Seldom that we get to brag our numbers are better than Middlesex, but in this case, we've lowered our population by 31% since March 13th. We've moved 610 people out of the 1,950-person jail. We do have the multiple ways of doing that. One, the sheriff sent out a note to law enforcement saying, please don't bring people to us unless they are really a danger to the community. So for nonviolent misdemeanors and low-level felonies, please just issue summons to appear later and don't bring them to us. That took our daily bookings from 70 a day to 25 a day, essentially overnight. Working with our partners in the city attorney's office and the county prosecutor's office, as well as the judges on the bench, we were able to take a look at folks who were in the jail, but for the ability to make bail, a conversation we've been having for well over a year that was getting slow traction, that was fast-tracked and implemented in approximately 4 days. And so to some extent, while necessity has been the mother of invention when it comes to these kinds of things, I would say really that this has just been the impetus for implementation. The invention work had been done by many of us over the course of several years, and things were on sort of a slow coasting process, waiting to build the political capital, waiting to build the community support and so forth. And then this COVID pandemic has simply really lit a fire and set the jets behind this. And so as Sheriff Parmelo used to say, we've become an overnight success. It just only took us 10 years to get here. And that's kind of the implementation process that we've gone through. We face the same challenges that everyone else does in terms of the quick releases. We are trying to release everyone who shows any signs of having an opiate use disorder of any kind with a Narcan kit on their way out the door. We're also giving recovery guides and resource guides, and we have retooled that resource guide to take into account those resources which remain open during the COVID crisis. The old resource guide listed an awful lot of places that have closed their doors and are no longer operating or no longer offering services at the moment. So we have gone through and created a new during COVID guide so that folks know if they see something in that guide that it will indeed be open and that they don't have to take a chance on something being closed because of the current issue. We also are very cognizant of the issue of overdoses for folks who are no longer staying in the jail, but the NA meetings, the AA meetings, the groups they used to go to are all closed. And what do folks do? You know, we know that the opposite of sobriety is or the opposite of addiction is not sobriety. The opposite of addiction is connection. And so when we have the folks who are extremely isolated and they have no way of checking in with other folks, no way of being around people who are going through the same thing they are at higher risk for relapse. They are at higher risk for overdose. They are at higher risk to either be victims of or perpetrators of domestic violence. And something that we have no doubt seen here is a coupling with the folks who receive stimulus checks. If you are someone who is battling addiction, whether you've been sober for 6 days or 6 years, and you are isolated, you have nothing to do, you're extremely stressed, and then someone drops $1,200 cash into your lap, it becomes very, very easy to take that money and very tempting to take that money and use that to go purchase your drug of choice. And so that's something that we're really trying to stay on top of, using our alcohol and mental health board, our peer supporters, and others to traverse the county to make sure that we are staying in touch with those folks who are at most risk. We've actually even created a handout and are in the process of creating a video specifically designed to talk to folks about when you get that check, here's how you don't spend it in a way that will hurt yourself. We also, as far as the high utilizer population is concerned, part of our issue has become where have they gone? Because we used to see them frequently at the jail, but they were all committing low-level crimes. So those folks are not being returned to the jail. They're being perhaps seen by the police in the community, perhaps seen by EMS, but we're not seeing them at the jail. So we don't have those frequent touches with them anymore, and so far we are also not seeing them in the shelters. What we are seeing, however, is folks who are discharged from the facility. We have had 11 positive inmate cases in the facility and some positive staff cases. Therefore, you can sort of assume in a facility like ours that everyone has potentially been exposed. And so upon release, those folks who have families to go to are being asked to self-isolate even within that family's home. Folks who are going into the shelter are going into our shelter system has expanded and created specific facilities for folks who have known exposures. And so we're asking that folks who are homeless who come out of the jail make sure that the Community Shelter Board and the other providers know that and that folks are put into those facilities for at least 14 days so that they have an opportunity to remain in quarantine. Other than that, we're doing all of the things, or hopefully most of the things, that Carrie and the sheriff mentioned. I'm interested to hear from my colleague in Bernalillo. I'm interested to hear from the questions that may be asked by the other participants on this. And with that, Mark, I think I've stayed within my time frame, and I'll turn it back to you.
Great. Thanks so much, Michael. And now I'll turn things over to Dr. Sam Howarth in Bernalillo County, New Mexico.
Good afternoon, everybody. I too want to echo the sentiments of the people who spoke before me and thank the Council of State Governments, the Justice Center, NACO, stepping up for the privilege of being able to talk with you guys today and hear the other presenters and what's happening elsewhere around the country. So I was asked to focus on what we're doing with frequent utilizers, which is related to COVID. And in a sense, we're kind of lucky because we have a pretty robust system in Bernalillo County that when COVID hit, we just sort of actioned it to a greater degree with a slightly different focus. So first, a little bit of background. So Bernalillo County is smack dab in the center of New Mexico, and Albuquerque is smack dab in the middle of Bernalillo County. So we are the largest population-wise county in the state, and we have approximately 670,000 people. As of yesterday, there were 738 cases of COVID in the county, 35 deaths, approximately 21,000 tests administered. So our rate in Bernalillo County is not that great. We've done a good job of social distancing and isolation. I'm talking to you from home. Of more concern in the state is what's happening in the northwest corner in 3 counties, McKinley, San Juan, and Sandoval. Collectively, they've had 1,711 cases with a population of 400,000. And the vast majority are Native Americans. And I haven't heard talk of that on the news. I've heard about a disproportionate representation of African Americans. But in New Mexico, it's clearly Native Americans. So that's the backdrop of COVID, what's happening in the county. We've had 1 case of positive COVID in our jail. We call it the Metropolitan Detention Center. It was running a census of just over 1,300 before COVID. I looked last week and we're down hovering around 1,200. That is not because people had been released, however. What's happened is the Metropolitan Detention Center has teamed up with our 2 law enforcement agencies, Albuquerque Police Department and Bernalillo County Sheriff's Office, and they are not booking low-level misdemeanors or low-level felonies, and specifically low-level felony drug charges. So we're not seeing the same churn through the jail that we do typically. The other thing that we have in place is we have what we call a resource reentry center. So almost 99% of inmates released from MDC are transported from the jail to the Resource Reentry Center. And there's like a metal gate that opens, the transport comes in, the gate closes. They don't have a choice but to go through the center. They can walk right out, but they have to walk through. In the center, they have access to navigators, case managers, food, coffee, sandwiches, a phone charging station, links to services, bus passes, Narcan, and additionally, they have access to what we call boundary spanning case managers. So these are intensive case managers. We have 6 of them. They work day shift and swing shift, and they look at the manifest, the people who are going to be transported from the jail, which arrives at the Resource Reentry Center about 30 minutes before the releasees, and they see if anybody on that list has been designated a frequent utilizer. And frequent utilizers are designated by these criteria. So they have to have been booked into MDC at least 2 times in the prior 18 months, and they have to have had at least 1 touch on our county-operated care campus, which is where our detox program, our public inebriate intervention program, our crisis stabilization unit, and our sober living supported aftercare programs operate. Then, with that criteria, we end up with a list of about 240 people, and we send that list to the State Department of Health. In New Mexico, we don't have a county-level system of health agencies. We have a state-run health agency, and we send them the first, last name, and date of birth of everybody on our list, and they validate that list by looking to see how many times each of the people on the list have been in the emergency department in the last 18 months. And I can't remember the exact percentage, but it's almost 80% have been. One individual on our list was in the ED 217 times. And keep in mind that he'd also been in jail a number of times. So he's cycling through the systems to a significant degree. So if somebody's on the manifest and is also on the frequent utilizer list, a boundary spanning case manager will reach out to that individual and offer to impanel that person on his or her caseload. And that person will follow the releasee into the community to connect that person with services. Each case manager has a caseload of 20, 25 people. They would be working in the jail to sort of create a relationship with these individuals, but they're not allowed in the jail currently. We are about to implement video conferencing, which will allow the boundary spanners to meet the potential client while the client is in jail and then meet them at the RRC when they're released. The other thing about the frequent utilizer tool, which is exciting, I think, is we have a subcommittee to our CJCC, which is a frequent utilizer subcommittee. And we literally yesterday, I reviewed a memorandum of agreement that would be signed by the parties allowing us to share our lists. And it was created by one of our public defenders, and it's pretty solid. It's been approved by the county and the city. So we're making progress towards being able to share my list with others, being able to get the managed care organizations lists. They put people on the list based on 2 criteria, which is number of ED visits and total cost to the plan. APD has already shared their list. The courts are part of this. We've got Metro Court and District Court. We've got the public defender, district attorney, the MCOs, the county, the city, pre-trial, probation, parole, all at the table in this subcommittee, not just the CJCC. So we're on the brink of being able to sort of cross-tab those lists and see if we're identifying the same people and what we would do about that and coordinate care and outreach, right? I think I will leave it there and attend to questions if anybody has any.
Great. Thank you, Sam. And now I'll turn things over briefly to Dr. Marc Stern to make a few remarks, and he'll also be available during the question and answer session.
Thank you. So I am the caboose. I will address a few loose ends. I was also asked to address the issue of testing. And so I'll spend a couple of minutes on that. And I'm going to preface my remarks about testing with, if at the end of talking about testing you're confused about testing, that means you really understood what I said, because the landscape is changing and it is confusing, and there are more gray zones than there are black and white zones with regard to testing. So it's not just a reentry issue, but it's so integral to reentry. That's why it's important to talk about. So there's two kinds of tests that you're hearing about. One of them is called the PCR test. The other is the antibody test. The PCR test actually tests for the presence of the virus, whereas the antibody test checks to see if you have responded, if your immune system has responded to the virus. And both types of tests come in two flavors. One is that they can be done in a laboratory, and the other is that they can be done as we call point of care. And the point of care tests for the PCR are pretty much little toaster-sized boxes that sit on a desk. And the point of care for the antibody tests, for the most part, look very much like urine pregnancy tests that everybody is used to. So a couple of shortcomings of the PCR or virus test itself is, first of all, it can be, point of care testing can be kind of slow. The tests, at least one of them, takes several minutes, could take up to a quarter of an hour. And so it's not the kind of thing where you're going to have hundreds of people that you can test in a short period of time. So if you're doing testing, for example, at the Sally Port as people are leaving, if you have one or two people a day, or even a few each day, that's one thing. If you're a large scale, it's releasing dozens of people an hour, point of care testing is not going to be a good solution. Another problem with these machines is simply their availability, and I suspect over time that will get better. But for the moment, getting access to them is going to be difficult if you don't already have one. Another problem with the virus test, the PCR test, is the risk of what we call false negatives, that a person is tested and the test comes back negative, and you assume that they don't have the virus and that they're not shedding and not infective, and that may not be true. Also, if you're sending the test to a laboratory, let's say you know somebody is going to be leaving on Friday, which is not usually the case that we know that in advance, but sometimes we do, and today is Wednesday and you send out the test, on Thursday or Friday morning, you may very well not have the test back by the time the person releases. There is also a risk, especially with the point of care testing of viruses, that we can see false positives. In other words, that the result says that the person has is shedding the virus, but in fact they may not be. And this is mostly going to be a problem with not maintaining the machine well, not maintaining things cleanly, and changing gloves, et cetera, between each test. The antibody test, switching to that for a moment, also has some shortcomings, the major one of which is that we don't still really know what the immunity means. By the way, there are two different results that come out of that test, and some of them both what we call an IgM and an IgG. The first one showing the earlier kind of immune reaction that people have to an infection, and the second one being the kind of reaction we mount later on that usually is sustained for weeks, months, sometimes longer for different infections. But the problem with this coronavirus, is we don't yet know whether a positive test, especially for the IgG, the long-lasting one, is actually a reflection of the fact that you're immune, that if you are exposed to the virus again, you can get it. I know that sounds kind of counterintuitive. Well, it says you're immune, you have the antibodies, why are you not going to be able to fight off the infection? And the reason is that we don't yet know for sure whether the tests that we're conducting are actually testing whether you have antibody in the type of antibody that will fight off an infection. So that's a shortcoming of the antibody test. And the last thing I want to say about the testing is to differentiate between two ways that we in healthcare use tests. We can use them for diagnosis, which sounds obvious, but it specifically means that we have a patient in front of us and we're trying to figure out what's going on with that patient, we do the test to find that answer. And that's called a diagnostic test. But in public health, tests can be also used for the purposes of surveillance, where what we're trying to figure out not necessarily what's going on with an individual, but what's going on with a community or a facility. So almost think of it as a diagnostic test for a building as opposed to a diagnostic test for an individual. So there may be a value for using one or both of these tests for surveillance purposes. There will be shortcomings to that because, as I said a few moments ago, the test may not be 100% accurate, but it may be accurate to be used as a surveillance tool periodically over time. What I mean by that is if we were to take a random sample of the residents of a jail, a sufficient size, not necessarily even everyone, but just a certain number of them, and we repeated that over time, they might perform just like election polls. It's a good analogy. We know that election polls are not 100% accurate. Somebody who responds to it and says, I'm going to vote for this person, may change their mind or may not even be honest. But if the poll says that this candidate has a 5% chance of winning, you're pretty sure she's not going to win. It might be 1%, it might be 10% of people who are voting for them, but they're not going to win. And also, if you take the poll in the same way over a period of time, you have a pretty good idea of how that person is trending. If they're 5% this week and they're 10% next week and 50% the following week, you have a pretty good idea that they're getting stronger. And so there may be a value, and I want to underscore the word may, for doing surveillance testing in our jails. This is something that CDC has not yet come out with for our setting, for the correctional setting. I'm hopeful that they will. And when they do, that's something that the organizations that have put this call together will help share with you. I'm going to wrap up with a few loose ends. One is that it does not have to do with testing, by the way. So the first one is that this is such an important period of time for jails to be connected, as I say, connected at the hip to your local health departments. A lot of the things that the previous speakers have spoken about are things that require you to be in close communication with the local health department, figuring out how to manage these really difficult patients who are getting out. So if you're not currently joined at the hip yet with your local health department, do it. If you're having trouble finding the proper person, NACHO is an organization that can help you with that, or just escalate up to the state health department and find out who the proper person is. Next thing I wanted to come back to is something that Sheriff Koutoujian and Kari Hill mentioned about the rush that we feel we're under for getting people out, and the side effect that can have. For example, the example that Carrie gave of somebody ending up sleeping in their car. And the take-home message from that is that I think the orders that have come out, the court orders that require you to release people within a certain period of time, can be problematic. I'm not saying they shouldn't have done them, but it puts you under pressure sometimes to release someone when they don't have an adequate release plan. And so to the extent that you have any input with the powers that be in your community to say, hey, you're gearing up to issue an order, can you make the order such that we can have the time to put together a release plan and not be rushed to get somebody out the door Friday, whether or not there's a good release plan, because that is, as we've said, dangerous. The next thing is that the CDC has a couple of good handouts on their website. I believe we're going to put a link to the CDC guidelines on correctional institutions. But in addition to that, other places, there are two good handouts. One for people who are not under suspicion, we don't think they have infection, on how they should manage themselves in the community. And the second one for people who are under suspicion of having infection or have it confirmed and are going home. And so we will make sure that those links to those 2 documents are available to you. You can just hit the link, print them out, and give them to people as they leave. Another give to people as they leave hopefully will be masks if they don't have their own masks at home. And I want to make my last comment about MOUD and opiate treatment. We've talked a little bit in the last few minutes about the good efforts that are being done at the 3 jails on this call about sending people home prepared to deal as well as possible with their opiate addiction. One of the issues or problems that comes up is giving them medication, and I'm here specifically thinking about buprenorphine, giving them medication as opposed to prescriptions. Up until now, many jails have been reticent to give patients actual medication, and if they do, they give it to them for very short periods of time. I think this is a moment to think about that and think about whether it's safe and whether you're able to not only give patients the actual medication, but also give it to them for an extended period of time. And when I say extended period of time, I mean a week, 2 weeks, or even longer, up to 4 weeks, depending on a lot of factors that are clinical factors, the reliability of the patient, their past history, et cetera. The reason for doing that is that we know there's a high mortality risk for people when they get out of jails and prisons in the first few hours, days, weeks when they get out of custody. And the more we can do to have them prepared, as I think all of you know, the more we can do to reduce that risk of mortality. And the more steps they have to go through to get their medication, the lower the chances are that they'll actually do it. And especially now in the time of COVID-19, the fewer things that they have to, the less transportation that they have to subject themselves to. In other words, getting on a bus, getting in a car to get to the pharmacy, and exposing others and themselves at the pharmacy. The more we can reduce those interactions, I think the more we can do to reduce the spread of infection. So on that note, I am going to wrap up and send it back to you.
Thank you so much, Dr. Stern, for that information. And now we have time for some questions and answers. Sheriff Koutoujian and Kari Hill unfortunately had to sign off at the top of the hour, but
Mark?
their email addresses.
Hey, Mark,
yeah,
we just want to let you know that
Yeah.
I have to jump off at the top of the hour, but Sheriff Koutoujian is going to stay on for about 5 to 10 minutes. And so if you have questions specifically for either the sheriff or I, if we could take those first, it'd be great.
Oh, okay, great. Yeah, we had one general question come in, which I think is great to start off with. And the question is, how are you identifying individuals for release during this time?
Yep, and I actually tried to respond because I wasn't sure if I could stay on the call. So I tried to respond to a few of these. I mean, our first criteria that we look to are elderly, chronic conditions. Those are the first ones we take a look, of course, and then check into their status as a sentence, whether or not they've got some short time left, if we can put them out on a bracelet, if they're under cover of a minimum mandatory that we have to get court involvement with. So that's the things we'll look at in the pretrial. Generally, we're looking for low cash bail starting under $1,000, and then with Mass Bail Fund, which is a nonprofit organization where people actually put up monies to be able to be posted for some low cash bail releases. Then identifying those with them, and then kind of just helping them make sure that we can get the paperwork ready when they came up to do a series of bails at one time in our lobby. The only problem with that, as I mentioned in my answer on the chat, is that for a lot of these advocacy groups, and I don't mean to speak poorly of them, but their goal is to get people out of the jail. And not that they don't care about them once they're out of jail, but that's not really their main focus, and they don't think about that very, very much. And so this organization was getting people out quickly, and their idea was to get them out before the shelters closed. To me, that's not really a great reentry plan. and you know, but that's just not the ideal reentry program. So that's how we did it: chronically ill, elderly, and then focused on them. And then as we kind of step down, just to decarcerate. I want to say one thing that I didn't really get a chance to say about this idea of decarceration. The fact is that we got to empty 4 of our dormitories here at the Middlesex Sheriff's Office. So when we went from almost 800 to 600. And we were struggling with social distancing, and we would have a case pop up here or there throughout our facility. When it came down to creating social distancing, when the population came down, now we were able to empty out initially 3 of our 5 dorms, and now the 4th of our 5 dorms to put them into some of the old tier sections that we had, or the pods and individualized cells, along with some limited movement so that the risk of transmission is much less. The only dorm that we have left, and by the way, as I said, we spoke with medical professionals each time, Dr. Elise Forcell, that Dr. Stern knows quite well and has advised as well. The only dorm that we have maintained as a dorm and plan to maintain as a dorm is a dorm that we created to help those with more mental health issues, because the issue of self-harm and suicide is so much at greater risk now more than ever before, that we want to make sure that we hold them in the dorm setting. And for those that know corrections, know that a dorm or more communal setting can be a much safer place for those that might be thinking about self-harm issues.
Great. And then, Sheriff, another question for you is, how were the PARI kits developed? Were they developed pre-pandemic?
Yeah, so this is an organization that has been around for a while. They have worked with police departments, in different forms. They started the initial where you could bring your drugs to a police station and drop them off and not be prosecuted for the crime and just ask for help. So they started with that, and they've evolved beyond that. They have these kits that they've given out, and the kits have changed. I mean, there have been Narcan before, but now there's a lot more in the offering. And again, the telehealth, which I think is really fascinating, is that we've worked them to provide telehealth opportunities. And again, I saw there was a number of questions about phones. We are working with a local non-profit organization to provide phones. I don't know that this has been as significant a problem. I should check with my folks, but we have been trying to do that as well. But the idea of these telehealth opportunities or telephonic opportunities with Boston Medical Center, they're one of the Graken Center out there is one of the greatest ones. Actually, it's being run by the former director of the Office of Drug Control Policy, Michael Botticelli. They're offering a number of telehealth opportunities through that too. The Narcan, and then that bridge prescription. I saw a comment that a 60-day prescription would be great, but that's something that I think was a little bit beyond what we felt comfortable in giving, and at least initially we wanted to get them to the point where we could set up that appointment in the community for them, in their locality, and then be able to get them to that with maybe a day or two extra margin for error should there be any more problems as they reenter.
Great. Thank you so much, Sheriff. I know that you and Carrie had to get going. Want to thank you for joining the webinar today, and remind people who are attending that their email addresses are listed on the next slide, and Sheriff Koutoujian and Carrie would be happy to follow up with questions. I wanted to turn
Thank you very much.
Thank you. I want to turn the first general question about how are you identifying individuals for release to Michael, and then to Sam.
Yeah, it's Michael. Generally the same way that the sheriff was doing that. We took a look at folks who were 60 and over, folks who were in simply because they had bail less than $1,000 that they couldn't make, charges that were nonviolent or non-threatening to the community. We still have not crossed the hurdle yet of the folks who are the most medically fragile. We're still arguing through, unfortunately, some issues regarding HIPAA and what the healthcare folks in the jail are allowed to tell the courts. Are they allowed to say that this person has a heart condition if that's not germane to the case? And so that is still a stumbling block that I hope we can figure out how to cross in the future. But basically, it was pretty much the same way that the sheriff described.
And this
Great.
is Sam. Currently, we're not releasing inmates. As I said prior, what we are doing is not booking people, which has resulted in about 100 people decrease as of mid last week. So that strategy has not been implemented in Bernalillo County. Also, a quick update, a colleague of mine who's on the call texted me and told me that in today's paper, they announced 3 new cases of COVID in our jail.
Thank you for that. And then we had a few questions clustered around a few different themes. And one of them is, how do you ensure access to services for people without access to phones or computers so they could access telehealth medicine? What are some ways that you can still ensure access to services during this time? Maybe Michael, do you want to go first and then Sam?
We still do have, there are some treatment facilities in town that are still open. Not all of them have closed. And so part of our revised resource guide will direct people to those particular facilities depending upon what type of treatment it is that they need. There was also a question, I believe, about, or similar to this, about what are we doing regarding harm reduction, not just handing out naloxone. And I would say that, again, there are a very small number of groups that are still meeting. They're meeting virtually. We're trying to get people connected to NA and AA meetings online if we can. I know that's still a question of what if they don't have a phone, what if they don't have the internet and the libraries are down, but that is still, we're not finding that to be as big of a problem as we thought it might be. And then also our Safe Point, which is our needle exchange wound care harm reduction facility here in town, continues to operate with no changes. And so one can always get harm reduction information and connection to basic medical care through that facility.
Great. And then Sam, do you want to take that one as well?
Sure. We're lucky in that we operate the campus that I described prior, and on that campus we have case managers who can assist people to connect to services when they leave the campus. We do the same thing through our Reentry Center, so that those 2 doors people can go through, and they're staffed by, as I said, navigators and case managers who can assist with connections to services and supports. Additionally, we have an email listserv, which includes all of our campus, not just campus, but RRC-based case managers. And the case managers are super active on that listserv. So they'll call a provider, say an inpatient program, and find out, 1, are they accepting new people? 2, what do they need to have in place to COVID-wise? Like, have they been tested, or is taking their temperature enough? And so they keep in touch with one another so they're as current as can be. It's my understanding through the Bernalillo County Health Council, which is a harm reduction focused group, and our harm reduction folks up at the Department of Health, that needle exchanges continue. We provide Narcan and Narcan training both on our campus and at the RRC. The council also provides Narcan and Narcan training. The needle distribution is handled by the State Department of Health through either their local offices or through nonprofit organizations around the state. And it sounds to me like not much has changed in terms of a reduction in harm reduction effort. If anything, it sounds to me like it's increased.
Thanks, Sam. And then, Sam, there were a few questions, some operational questions about Bernalillo County's Reentry Center. There were questions about whether it's 24/7, who the boundary spanning case manager works for, and if personal protection equipment are required for those staff. I'm not sure if you can speak to any of those or elaborate on them.
Yeah, no, I can. We operate 24/7, 365. We run 3 shifts. like I said before, the boundary spanners cover the day shift and the swing shift. Most of the transports are happening during the swing shift, so that's an important one to cover. The boundary spanners work for us. They work for the county. So it's convenient because then they're part of our system as opposed to a contracted entity. And yes, our staff we have hand washing stations outside of the Resource Reentry Center and our campus. We take temperatures and we wear PPE.
Okay, great. And then there were a few questions around the topic of people who are releasing, who are homeless or at risk of experiencing homelessness, and with shelters or family unwilling or unable to take these people. What are some of the alternatives or alternative placements for these people who are released? Maybe Michael, and then we'll do Sam.
This is Michael, and this is gonna be a cop-out answer, sort of, but we had this conversation with our shelter board and our shelter who oversees all of our shelter providers here in the county early on in this process. And one of the things that we came to the conclusion of was that just because someone was exposed to COVID-19, the shelter board would not use that as an exclusionary criteria for shelter. In fact, they've expanded the number of beds that they have. They've rented an old empty hotel, and that's where they're quarantining folks who have known exposure. So quite honestly, we haven't seen that because we worked with our shelter board to ensure that that would not be the case from the beginning. They've also opened up the same shelters that they normally would in a winter overflow situation. That's about the only time here in Franklin County, if the temperature's got to be below 0 degrees or something, that you can get into shelter if you are a registered sex offender, for instance. But that level of shelter has also been open during this pandemic, and so we could even get folks who normally would not be able to go into the shelter system under these conditions. So I guess my answer to that question is we precluded having to answer that question by working with our shelter board up front to make sure that it wouldn't happen. I'm not sure how that helps if you are in the situation.
So this is Sam. We do the same thing. Not we, the county, but we, Albuquerque, the city, have extended the hours of our shelter, the city-run shelter, to 365. And it runs at about 450 people. They do COVID testing out there. They also have hand washing stations and PPE. We also have various housing vouchers for either short-term motel stays or longer-term supported housing, including case management. And we're also in touch with the local smaller shelters. So again, people can call and say, from the RRC, for example, and say, do you have space at this shelter? We can arrange transports. We also provide bus passes.
Great, thank you. Another question we have is, was there any specific public health guidance you received that you implemented regarding release that you would say is the best practice? And Dr. Stern, I'll have you start this one first, and then we'll go to Michael, then Sam.
I'm not sure I understand the question. I think if I do, it's all of the factors that we're considering, and I'm not sure if the question is about whether to release or release.
I'm not sure. Yeah, the question was, is there specific public health guidance you received regarding release that would be a best practice?
The answer is things we've got considering the totality of risk. Well, first of all, if we're talking about whether or not to release, the calculation before COVID-19 the public safety calculation had only to do with the risk of harm to person or property or the likelihood of somebody coming back for a court appearance. Now the definition of public safety is wider. It's the risk not only to the individual release, but the risk to the public of not releasing somebody, and that translates in two ways. the risk of somebody, especially the risk of spreading infection in the facility, and a staff member, an officer, a healthcare person, another staff member going home with it and taking it to the community. And the second risk is associated with those high-level vulnerable people that the CDC defines. When those people get an infection in the jail, they're much more likely to become seriously ill and go to the community hospital and use up a scarce community resource. So the decision of whether or not to release somebody, the best advice, the best public health advice is to take all of those factors into consideration to figure out who should go and who should stay. In terms of, from a public health standpoint, releasing somebody, the issues that we've been talking about of making sure that they have a plan, the person who is going to have trouble operating in the community, the person who doesn't have a home, doesn't have the proper home, is not going to be able to get food and other items. They need a plan, and the local resources, including the public health department, are the people to touch bases with and say, we're having trouble figuring this out. Do you have any suggestions? I'm hoping I'm answering the question. I'm not 100% sure.
Thanks, Dr. Stern. And then Michael or Sam, I'm not sure if you want to add anything to that.
It's Michael. I'm not sure if I can add much to that. We've been in contact with our health department since early on, and especially in regards to how could they help us take a look at any congregate housing setting. What would they say to any place that had this many residents in terms of best practices, and tried to follow that. Decarceration has allowed us to get closer to social distancing guidelines and so forth. And I'm actually texting simultaneously with one of the deputies from our sheriff's department in research and development, who points out that the guidelines have somewhat evolved and changed, and we've tried to keep up with them. But you remember at the beginning, the guidelines the CDC was giving regarding masks and gloves and distancing and so forth have continued to evolve over time, and we've tried to evolve what we're doing inside the facility in the same way, while still trying to decarcerate those folks for whom it's safe for the community and also safe for them to be released.
This is Sam. So we are in regular contact with our Department of Health, our State Department of Health, which includes email communication and teleconferences. And we have two people at the Department of Behavioral Health Services who are really focused on public health writ large. And between them, we've been able to gather and distribute an incredible amount of information towards the public benefit. A lot of it including crisis lines and call lines and mental health support, harm reduction, housing, connection to services. I wanted to back up based on something that somebody else said, is currently our MDC is releasing folks with prescriptions for 14 days, which then once they make connection at the RRC, they can be connected with a clinician who can re-up that prescription. And the other, this is a quasi-public health issue. One of the things that we focus on is if people have been in jail for longer than 30 days and their Medicaid has been switched off, we work with our Human Services Department to reactivate that Medicaid as quickly as possible.
Great, thank you. And another question we have is, are you doing anything to notify alleged domestic violence victims of the defendant's release?
This is Michael. We are statutorily obligated to do that under certain circumstances in Ohio, and with the law that was passed last year, those circumstances are greatly broadened. And so the answer to that question is yes. When domestic violence offenders, perpetrators are released, we're following the law in Ohio, and that does mean a dramatic increase in terms of the notifications to victims.
Mark, this is Mark. There are two loose ends I would like to comment on.
Sure, go ahead.
Yeah, so one, there was a couple of questions, both in conversation and on the question list about the number of days of prescription. I think it's a good question, and I touched on it very briefly when I was talking about MOUD and buprenorphine, but I think it's a broader question about any medication, really, because our patients are on more than one medication very often. So I think there's a number of factors that I'm going to throw out. The first and most important is really the comfort level of the prescriber. That's based on obviously their own training and knowledge, but the patient, their history, and the nature of the medication that we're talking about. So some providers are going to be comfortable with only a few days supply, others are going to be comfortable with a longer supply, and that is regardless of any that evidence-based practice or recommendation that someone would come out with. Ultimately, it's going to be their decision. The cost is an issue if you're going to give them medication versus send them out with it. Now with reduced populations, we have fewer patients to take care of. That's helpful for cost management, but on the other hand, we're all hurting in our budgets in COVID time. Whether or not the patient has insurance and is able to fill a prescription at the pharmacy is an issue. And again, as I mentioned earlier, their transportation to the pharmacy and their likelihood to be able to get there. So I don't think there's any set rule anywhere from something a day or two to until you know they can get their medication to 60 or 90 days is not unreasonable. Again, as long as clinically speaking, the prescriber thinks that that's safe to do. The other loose end I wanted to comment about that came up in the chat and orally was the question of HIPAA. I think it's also a really good question. I'll offer two thoughts. Number one is that HIPAA allows an escape clause for penologic need. And I think if we're talking about a population of people and saying there is no question that there's a penologic need for the safety of the institution, the safety of the community to be downsizing our populations. So I think that I'm not a lawyer, but I think that would provide some justification. And the other way to deal with HIPAA has always existed, is getting a patient's consent. So if there's any question about whether you can put in a response to a court pleading or in any official document that somebody has a disease, and by the way, I think one of the suggestions on the chat box was to simply say they meet the criteria of the CDC without saying what that criterion is or criteria for that person. That's I think a fine solution. But in addition to that, going to an individual and saying, hey, we want to submit something to the courts, can we say what you have? If they give permission, there's no HIPAA problem. Back to you, Mark.
Great, thank you, Dr. Stern. Another question we have is, how are agencies responding to judicial orders releasing misdemeanor incompetent to stand trial clients without any discharge plan? Maybe, Michael, do you want to take this first, and then we'll go to Sam?
Yeah, and I think there's some of these cases that we get into, whether it's incompetent to stand trial, whether it's, I think in maybe the chat box rather than the Q&A, someone said, and what do we do with sex offenders who have dementia or folks who just cannot be placed in nursing homes, cannot be placed in shelters. They simply won't take them. What we're finding is that we had those same problems pre-COVID. I wish we had good answers for them. What we really end up doing is taking those cases one by one and putting all hands on deck and trying to call everybody that we know and explain that one circumstance to try to get that one person placed. We do not have a good overall solution. We didn't have a good solution for these extremely difficult to place folks before COVID. I think all this has done is brought this more pressure to a point or put a finer focus on these issues, but we equally don't have a good answer during COVID, just as we did not before COVID.
This is Sam. Like Ohio, we do notify when people who have been incarcerated for domestic violence are being released. Like Ohio, we struggled with the same issue before, and we struggle with it now. The one thing that I will add is that, and given that we're not releasing people from the prison until they've completed their sentence, is that we do have a team of transition planners who were working in the jail. And when anybody gets booked into MDC, they're administered what we call an intake screener, which measures risk of recidivism, alcohol or substance use challenge, and behavioral health challenge. And it's 1 to 8 scored 1 to 8. And the transition planners focus on the people who score high, a 6 through an 8. And pre-COVID, they would go into the jail and meet the people and offer to do a transition plan. And most people accept that. Again, the RRC knows who has received a transition plan. And when they get the list of people who are going to be transported, they look for those people too, so that when they come to the RRC, they can offer to help assist them with whatever it is that's in that plan. So there is a pretty robust transition planning element to the work that we're doing, but it's not related to jails deciding to release additional people, and it didn't emerge from COVID. Now they're doing it through teleconferencing until COVID passes.
Great, thank you, Sam. And I know that we're coming up on time, and I know that there were a number of questions that we weren't able to answer, but this webinar is being recorded, and we'll have the recording available by next week. And for the panelists, their emails are listed on this slide here in the, there we go, the last slide in the presentation. And they'd be happy to follow up with people individually for unanswered questions. And also, if people have questions for either me or Risë at the Justice Center, we'd be happy to send resources or route your questions appropriately. I want to extend a big thank you to all of the panelists for speaking on the webinar today. And thanks to all of you, the attendees, for joining the webinar. And again, we did record the webinar, and we'll have it available by next week. And also keep a lookout for the COVID-19 reentry checklist that Risë talked about. That should be released either later this week or next week. And you can sign up for the Justice Center's distribution list here, and that checklist will be sent to that distribution list. Thanks so much, everyone. Have a great afternoon.